Hello and welcome to this poster session on bronchiectasis. My name is James Chalmers. I'm a consultant respiratory physician and academic from the University of Dundee in Scotland. We've got a fantastic lineup of posters for you on different aspects of the investigation and management of bronchiectasis. And I'm here with my colleague and friend, Tim Axmet.
Thanks, James, and glad to be with all of you here. And Diego, from one U.S. To another, great to see you, and I'm glad you submitted your poster. What a fantastic conference this, in fact, has been. And again, just really pleased that there's been as great participation internationally, and I'm looking forward to this session. I would share that one of our colleagues will not be joining us, so we do have just a little bit more time with some of the posters. And with that, I'll maybe turn it back over to James and we'll toggle back and forth as we go through the posters.
Absolutely. So the way this is going to work is that we'll have about 5 minutes for each presenter, but because we've had a couple of dropouts, we've got a little bit more time, which means we can allow a bit more time for question and answer. So I'm going to suggest to the speakers that we have about 3 to 4 minutes with the presentation for the data, and then we'll open it up for questions for 3 to 4 minutes, and we'll see how that goes through the afternoon. Hopefully some good back and forth, some good discussion, because these are some really interesting posters. So the first poster is really great to welcome my friend and colleague Michael Steinberg, exploring factors associated with acquisition and chronicity of infection in bronchiectasis, a population-based study.
Hi, it's great to be here, and thank you. Can you see my slides?
We can.
Yes.
Okay. So, sorry, to start off, we all know that chronic infection with Pseudomonas, but also other bacteria, are associated with adverse outcomes. But we don't know which factors are associated with a new infection and persistence of the infection. So using our Health Maintenance Organization registry of the population, we wanted to determine factors that are associated with a chronic infection after a new isolation of Pseudomonas or Haemophilus, the two most common organisms in bronchiectasis. So we search a population registry for bronchiectasis with at least 3 or 4 respiratory samples for new or chronic infection. And we define chronic infection as at least 2 positive cultures 3 months apart in 12 months. And we use hazard model to assess risk factors both for a first infection and for a chronic infection, and also logistical. So this is the flow chart of the patients. We started up assessing a new infection after 2 negative cultures. We started with 4,000 people with bronchiectasis, and after excluding people with less than 3 respiratory cultures, we ended up with 1,744 patients with bronchiectasis. And then we looked at people with 2 first negative cultures for Haemophilus and for Pseudomonas, and looked at the third culture to see whether they grew each of the organisms. And then we looked at people with at least 4 respiratory cultures to see for people who grew Haemophilus and Pseudomonas after initial negative cultures who became chronic. And if you see that we started off with 1,305 people with bronchiectasis and 169 new infections with Haemophilus and 297 new infections with Pseudomonas. Of the Haemophilus, 23% became chronic, and of the Pseudomonas, 33% became chronic, and this was statistically significant that Pseudomonas is more likely to become chronic. We assessed multivariate factors for new infection, and looking at Pseudomonas, COPD, primary ciliary dyskinesia, previous Haemophilus, and alcohol abuse were all associated with an elevated risk of infection, of a new infection. For Haemophilus, which was interesting, the old age and COPD were associated with a less risk, a diminished risk, and PCD were with a higher risk. Looking at the people with a new infection and looking at factors for a second infection within 1 year of the same organism, which was defined as chronic, For Haemophilus, the same factors were associated with an elevated risk for chronic infection or two infections, which was younger age, no COPD, and PCD, which raised the risk. And for COPD, we didn't really find factors. The only factors that surprisingly were associated with an elevated risk for chronic infection were hospitalization and treatment with anti-pseudomonal antimicrobials. So these factors did not only did they not lower the risk, but elevated the risk. And we also saw that survival of chronic Pseudomonas versus single or intermittent Pseudomonas was worse. So to sum up, PCD was associated with a higher risk for new and chronic infection with Haemophilus and for new Pseudomonas. Haemophilus infection was associated with a younger age and no COPD, and Pseudomonas was associated with COPD previous Haemophilus. The first Pseudomonas infection was associated with a higher risk of becoming chronic than Haemophilus, and chronic Pseudomonas was associated with increased mortality compared to single or intermittent Pseudomonas. And chronic infection with Pseudomonas after initial isolation, antibiotic treatment and hospitalization did not reduce the risk but elevated the risk. And this could be explained by reverse causality. The more severe patients were more likely to be treated or hospitalized, and these were the ones who became chronic. And this really highlights the need for Pseudomonas eradication trials. So thank you very much. Sorry to go over time.
Not at all. We've got plenty of time this afternoon, so it's great to share the data in that detail. We'll open it up to questions, so everybody who's a speaker in this session can also ask questions. So please just open your microphone, ask a question. I'm gonna start off with one, which is you touched on reverse causation in the conclusions there. From 4,000 patients with bronchiectasis, only several hundred were actually chronically infected. Do you think that's real, or do you think that's down to biases associated with sampling? Because certainly in my practice, when patients are referred to me, they've often not had sputum cultures very frequently.
Yeah. So we had to draw the line between the more cultures and more patients. So the more patients the more cultures we needed to be sure of chronic infection, the less patients that we had. So a lot of patients did not have sufficient number of respiratory cultures, and we excluded them. So we actually excluded the majority of patients in our registry. And you're absolutely right. Maybe there's more patients who are chronically infected.
And on the same line, do you think the PCD signal is real, or is that we do lots of testing in PCD because we think it's a more severe condition?
All of these people had at least 3 or 4 cultures. So we wanted to make sure that we do capture all of the samples, not only the PCD. So I think the risk of this is relatively low.
And Michaela, have these findings impacted either your or your colleagues' practice based on these types of results? I mean, are you doing more cultures now, or encouraging colleagues to do more cultures?
Well, this is really a community-based study, so it's what the community is doing, and the number of cultures per patient were very variable. So we had patients with 20 or more samples in this time period. But I thought you would ask me about the eradication, which in most cases was oral, and I would guess that we're not doing a good enough job eradicating Pseudomonas.
Since we've got time, I'm going to ask one more question because I really like these data. Haemophilus is classic in every textbook is associated with COPD. Yeah. So what's going on here?
That's really surprising. Yeah, it really surprised me as well. So I would think that in the context, I can answer this in two ways. It's not that COPD patients did not have Haemophilus; they just may have less Pseudomonas than bronchiectasis. And the second is that probably when you diagnose COPD within the context of bronchiectasis, it's the ones with the low lung function. So we did have lung function, but only for about a third of our patients. This is a problem with registry, community registry analysis. So I think this is really a surrogate for low lung function. So the people with Haemophilus were the younger and the ones with a better lung function. And then reversely, this made the risk higher.
And just one follow-up point there. It was surprising to you that there wasn't an association with FEV1 with the Pseudomonas?
Yeah, it was surprising, but again, being a population registry, I think we can do better with the lung function, and there was absolutely no association, which was surprising to me. When we looked at FEV1 specifically, not just a diagnosis of COPD.
And I would just make a pitch, and I can't speak for the practice in the UK, but certainly in the States, we are constantly on our colleagues in the community to try to get more cultures at baseline as well as on follow-up, trying to understand what the microbiology looks like in sputum, even when patients are not having exacerbations. I think that really does help inform us as far as our practice. And I'll leave it to James. I mean, I know you've done a lot of work in that area.
Completely agree. So thank you very much for that great presentation and great answers to the questions. I know you've got to leave now to chair another session, so
Yes,
that's no problem at all.
So thank you and goodbye.
Thank you.
Sorry
Great talk.
for not hearing the rest of the posters. I'm sure they're excellent as well.
You're doing an important job for the conference, so thank you. So we'll move on to the next poster. Tim, do you want to introduce the next one?
Sure. This is Rebecca McLeese and comes from a group, it looks like from James as well as the Belfast group, and looking at one of these very interesting and kind of time-ridden questions that we all have when it comes to bronchiectasis is quality of life issues. What are the instruments that can help us the most and inform us as far as our clinical trials, as well as then as far as clinical impact goes. And with that, I'll introduce Dr. McLeese, and who's from Belfast.
Thank you very much for the introduction. And so hopefully you can see my slides okay?
Yes.
Great. So I'm going to be talking today about the psychometric properties of health-related quality of life questionnaires in bronchiectasis. So patient-reported outcome measures, including health-related quality of life, are accepted as primary outcome measures and are mandatory in clinical trials to assess the effects of treatment and how patients feel. Evidence from recent clinical trials support the use of some medications in bronchiectasis. However, a number of recent trials have failed to demonstrate a clinically important or statistically significant change in their primary outcomes, and that includes HRQOL. The reasons for this are multifactorial, but include a lack of bronchiectasis-specific clinically validated outcome measures. And the need for robust outcome measures in clinical trials has been emphasised by regulators, with particular emphasis on tools that measure patient-reported outcomes. So the objective of my review was to assess the psychometric properties of all HRQOL questionnaires available in bronchiectasis. This includes reliability, validity, and responsiveness. So we performed a literature search in 5 electronic databases. The search spanned studies between the years of 2014 and 2019, and we also included studies published prior to 2014 that were reported on in a previous review by Spinu and colleagues back in 2016. We then extracted HRQOL data and then assessed each for psychometric properties. So 130 relevant studies were included. Of the 12 HRQOL questionnaires, 2 were bronchiectasis specific, 7 were respiratory specific, and 3 were generic. And the most popular used questionnaire was St. George's respiratory questionnaire. And in the interest of time for this presentation, I will present the data from St. George's Respiratory Questionnaire, along with the two bronchiectasis specific questionnaires, QOL-B and BHQ. So HRQOL questionnaires in general had good reliability, internal consistency and test-retest reliability, were both acceptable in the majority of studies. Test-retest reliability was most commonly reported over a shorter time period, and very few studies actually looked at this over a longer time period, despite the majority of RCTs having a duration of longer than 6 months. HRQOL questionnaires were most commonly able to discriminate patients based on disease severity, exacerbations, and bacteriology, as well as a range of other symptoms. And we anticipated the strong associations between HRQOL and symptoms such as cough, dyspnea, as well as anxiety and depression, as these contribute to many of the domains within the questionnaires. We did find weaker associations between HRQOL and objective measurements, highlighting that HRQOL questionnaires assess a unique aspect of health. The majority of HRQOL questionnaires were responsive, and the meta-analysis showed a difference between treatment and placebo, which was generally significant across the questionnaires. The effect size was highest in St. George's Respiratory Questionnaire. However, we did find that the minimal clinically important differences for the majority of questionnaires were determined from other disease populations, with only QOL-B deriving these from a bronchiectasis population. And in all studies, all HRQOL questionnaires met the standards for floor effects. However, some studies failed to meet the standards for ceiling effects. In conclusion, this systematic review provides new synthesized data for 130 studies on the psychometric properties of 12 questionnaires available in bronchiectasis. This review highlights the importance of the psychometric properties to inform choice of HRQOL questionnaires in clinical trials. St. George's Respiratory Questionnaire was the most widely used questionnaire, and it had good psychometric properties. However, good psychometric data are also growing on bronchiectasis specific questionnaires such as QOL-B and BHQ. And we believe future studies should focus specifically on the questions which show the best potential in bronchiectasis. Thank you for listening. I'm happy to take questions. Sorry, I think you're on mute.
Sorry, great presentation, Rebecca. And I'll first open up to the group whether there's any comments for Rebecca. And as individuals are maybe teeing up or coming off mute, I was struck by the difference between the QOL-B and St. George in the treatment effect, and why there seemed to be such a difference in this way. And what was your impression about that?
Yeah, we were also surprised at this, and for QOL-B, with there being so many domains that different groups have looked at, this might have something to do with it. We did include all domains rather than just the respiratory symptoms domain. So it could be if we were to go back and look at just the respiratory symptoms domain, there may be a better effect size there.
Okay. And can you just expand a little bit about where the interest in the psychometric part of the instruments were, and how you came about that and how you landed on that area?
Yeah, so a previous meta-analysis was published back in 2016. And since this time, there's been a huge amount of clinical trials that have looked at health-related quality of life instruments as a primary outcome. And because of the discordance between some of these instruments, it's clear that there needs to be better validity for some of these outcomes. So that's really what brought us to looking at this again in 2020, because there's been just so much, and new questionnaires as well. So there's a couple of new bronchiectasis specific questionnaires which haven't been looked at previously.
Excellent. I mean, this is fantastic work, and is so much needed in this space as we move forward with our clinical trials and even for patient care. So I can't encourage you enough to continue with what looks like just great work.
Thank you very much.
Any other
Okay.
comments? Okay.
Any of the other
James?
presenters want to ask any questions? Okay, I feel like I shouldn't ask too many questions on something I'm a co-author on, so.
No, it's great work.
Happy to take questions.
Do you have any other comments, James, or things that you might just?
No, I mean, I think that's beautifully presented. It is really important work. We've done so many trials at costs of so many millions of dollars, and we need to make sure we're measuring things correctly so that we get proper results. And this is important work towards that goal. So well done, Rebecca, and keep at it. So should we move on to the next presentation? So we're going to change gears substantially, going from quality of life to another fascinating aspect of bronchiectasis, which is the microbiome. Some of you will have heard the presentations earlier in the day around this topic. It is a really important topic in bronchiectasis. And our next presenter is Martina Oriano, who's from Milan in Italy. And the title's Clinical Characteristics Associated with Low Sputum Microbiome Diversity in Bronchiectasis. Martina.
Thank you very much.
Perfect.
Can you see my screen?
Yes.
Okay. So, airway infection is one of the major components of bronchiectasis pathophysiology, and airway dysbiosis is associated with disease severity and inflammation in many respiratory diseases, including bronchiectasis. So the aim of this study was to identify single clinical characteristics independently associated with low microbiome diversity in sputum of bronchiectasis patients. Adults with bronchiectasis in stable states were enrolled for this cross-sectional study. Patients underwent clinical evaluation, microbiome analysis, and inflammation assessment in sputum. Patients were so divided into groups based on median levels on channel diversity. The two groups were very similar in terms of demographics. However, low microbiome diversity patients showed a higher adjusted by BSI, excluding microbiology, and a higher number of lobes involved at CT scan. Univariate analysis resulted in the association of FEV1 less than 50%, radiological involvement of more than 4 lobes, PCD, and adjusted BSI. However, multivariate analysis confirmed just FEV1, radiology, and PCD. We also characterized these patients from the microbiome point of view and the inflammatory one. From the microbiome point of view, we saw an enrichment in Pseudomonas and Staphylococcus and Streptococcus, and mostly in the low diversity group, while the inflammatory biomarker analysis showed an increased active neutrophil elastase, increased TNF-alpha, and increased IL-1 beta in low diversity samples. In conclusion, this experience reported the association of microbiome diversity to radiology, respiratory function, and PCD as an etiology of bronchiectasis. It showed both the high presence of Pseudomonas, Staphylococcus, and Streptococcus genera and a high inflammatory environment in low diversity samples. And we underline the need of new specific intervention aimed at treating airway dysbiosis that might help in stabilizing or slowing down the functional and radiological progression in bronchiectasis. This tool may lead to new personalized medicine approach in bronchiectasis. Thank you very much.
Very good. I don't think I've ever seen so much data presented in 3 minutes. So that is
fantastic.
Microbiome data is big data, and you've presented that in a really coherent way really quickly.
Yeah.
So I congratulate you.
Thank you.
I'll kick off with a question, but any one from the other panelists, please chip in with a question. You divided the patients using the Shannon Diversity Index. Yeah. There's obviously lots of other types of diversity or dominance indexes. I'm wondering why you picked that one and what that really means.
Well, we usually use Shannon diversity because it's a summary measure of richness and evenness, even if that's true that the use of not only index, but many of them may have made this analysis more complex and more complete. We are also working on unsupervised clustering on this patient. That is ongoing in this period, but it seemed to be simple measure that should have given some hint, at least, to see something in clinical data.
Very good. So you showed an association between low diversity and inflammation. Do you think that that's causative, or do you think that's indirectly showing you something else?
Well, the interplay between inflammation and infection is very close. And we know that inflammation is very driven by the bugs that are inside the samples. So we know that there is a very high relation between neutrophil elastase and Pseudomonas. For example, we know that neutrophil elastase is driven by gram negatives. So yes, we know that there's an interplay. Bacteria can drive inflammation, and but I won't say that there's a causation, because this is just a cross-sectional study. So I won't say that there's a causation.
Yeah, very difficult to prove conclusively, but you're absolutely right. There's an important interplay there. Tim?
Yeah, my only, and it's fantastic, like you say, as much information. And as they say, you've gone to the Shire and back again. And so what I'm asking about is, do you have a sense with your data? Have there been individuals that have gone from low diversity to high diversity and back again, or vice versa? And have they paralleled those same trends as far as your inflammatory biomarkers?
Well, we know that there's a very high fluctuation in microbiome. However, we didn't do anything like this in this study because this was just one assessment, one microbiome assessment and a parallel inflammatory assessment. So we did not prove if there was a fluctuation in the microbiome or in inflammation, and we didn't look at that.
And so the point would be, just as James was, I think, alluding to, is what's cause and effect, and can we impact that? That is, can we change the inflammatory phenotypic response to either improve or worsen the diversity index, or vice versa? Could we potentially nebulize a more diverse microbial population, and in the process enhance the inflammatory profiles there. So to have some longitudinal or durable information may help again inform us even a little bit more along these lines. Absolutely fantastic work.
Yes, well, there are many works doing this in the gut department. So the idea is that maybe modifying the microbiome, we can work on an inflammatory side and modify the chronic inflammation that we know there is in this kind of patients.
And just out of curiosity, James, what do you think drives that? Is it the inflammatory side of things or the diversity side of things?
Yeah, so I mean, I think I'm going to sit on the fence and say it's probably a two-way interaction. I mean, almost all biological systems are two-way interactions. So I think you probably get infection drives inflammation. Inflammation then selects for certain pathogens, and you get into a vicious cycle that exacerbates things. But it's very difficult to prove. But this is really important work, and will lead us to a better understanding of this phenomenon. So thank you, Martina. Great talk.
Yes.
Thank you.
Fantastic. Well, I guess then next would be I have Caitlin Smalley from in her group from the Imperial College in London, and is presenting some information, and again with a bit of a change as well, on co-designing a digital self-management plan. And this is something near and dear to us that whether we like it or not, our patients are engaged in the care that we deliver. So with that, Dr. Smalley, are you with us?
Yes, I am. Thank you so much.
Okay.
Yeah, I'm really happy to be here today. I'm actually a social and behavioral scientist presenting on behalf of a multidisciplinary team that worked on this project. So my group of co-authors are 2 respiratory physiotherapists, 2 respiratory consultants, 3 patients, and a healthcare designer, and some other social scientists like me. And we came together for this project. It really came out of some work that we were doing around understanding the knowledge and skills that people need to self-manage bronchiectasis effectively. And bronchiectasis is a condition that I find really interesting as someone who studies self-management and what's needed in order to be able to do it well, just because of the level of sophistication that patients with this disease end up developing in terms of knowing about what their baseline symptoms are, knowing what to do when they recognize deterioration, being able to recognize that they're deteriorating really quickly, and then even all the way to really kind of sophisticated medical topics like engaging their clinicians on the kinds of antibiotics that they're using and should be using as the first line, flagging when their prescriptions aren't right, understanding the bugs that are in their sputum cultures. It's really quite exciting to talk to some patients that are, also not medical doctors, really being able to speak about this with such fluency. But over the course of these conversations, it really came up as well that people don't develop this knowledge overnight, and that it really is the clinical team can really do some things to support patients in that effort. And one of the things that the team at the Imperial NHS Trust do is they provide a self-management plan to everyone that they treat with bronchiectasis. The problem with this plan currently, though, is that it looks like this. It is it's an A4 sheet of paper that has a tremendous amount of information on it, but it's not in the most easy to read format. Patients will either put it up on their fridge or crumple it up in a drawer and forget about it. Sometimes GPs refer to them, sometimes they don't. And so as a group, we started thinking about, well, what can we do to make this information more user-friendly? So convened this interdisciplinary group with a bunch of different, with patients and clinicians who would equally be using this self-management plan, and walked them through an experience-based co-design process. So a series of workshops to think through what is it that this tool really needs to be able to accomplish, what's the ethos and the principles behind it, what kind of information it needs to contain, and then figuring out how to translate that into a software product that we could also actually use and embed in the patient-facing personal health record that the trust uses. So we did this over a series of 2 workshops with me and my co-authors. We then brought it to the entire bronchiectasis MDT at the trust to work with us on identifying the highest priority features to build out first. And I was actually hoping that I'd be able to share with you today our prototype, but our software team is still putting finishing touches on that. But we're looking for, in the beginning of the new year, to be able to start rolling this out with patients. This is, as a co-design study, it's kind of a bit different than a normal typical research study, but it has been a lot of fun to work with patients and their care teams to really figure out what they need in order to self-manage in an effective way. And, you know, just thinking about previous research showing that doing user experience and design research really does help with the uptake of new technologies. And that was really the goal of this project. We are looking forward to rolling it out with patients, and hopefully we'll be back next year to report back. But yeah, thanks very much for the opportunity.
No, this is a great start on a very important topic for all of us, and will have some impact even on for clinical research purposes potentially. And again, I'll open up the discussion to the rest of our group. Anyone have questions for Catherine? Caitlin.
Caitlin, this is Diego. Hi, nice,
Hi,
very nice work. Fantastic. So it will work as how, if I understood, the patients will log in their data. Is it through a computer or through a mobile device, or I mean through your phone, or both?
So it's both, actually. It's not a smartphone app. It's so the platform that we're using is called Patients Know Best, and that is a software product that can talk with the electronic health record from both secondary care and primary care. So they feed in parts of the health record so that the patient can access them. It also has other features like messaging features and other things and self-management, things like this, to help patients keep track of their care.
Yes, that's fantastic. So I do a lot of severe asthma work. I have a severe asthma clinic. And so we have a tool that we're trying to develop that's a little bit similar, but the patients will message you and they'll self-monitor. And when they have a flare-up or an exacerbation, they'll start pinning you until you respond. And sometimes they need steroids and antibiotics and whatnot. And, you know, bronchiectasis will exacerbate just like asthma will exacerbate as well. So it's always the fine balance between how much contact the patients are going to send the providers or the caregivers versus how much is relevant. So some of our providers, for example, have been a little bit resistant because they feel like they're going to be flooded with too much information overload. So how do you envision that from happening so that you can you negotiate having good contact with the patients, but at the same time, you know, not overloading the providers with so much information?
Definitely, that's really important. So this is really designed to be the first point of contact for the patient is the software itself. So what we ended up designing is almost like a triaging tool. So we have a series of questions, symptoms that people can report. And so our first bucket of questions are things that are, you know, chest pain, coughing up lots of blood, things that are, you need to go to the hospital right now, because that's the most important first line, is making sure that we keep people safe. Then we have a tranche of questions that are related to COVID symptoms, and then we direct them if they're experiencing any of those symptoms, then they'll get a recommendation that's COVID specific. Then they will be guided through some questions that would maybe suggest that they might have an infection. And then there's an infection protocol. And so the infection protocol is not get in contact with us right now. There are some things that they do, and the clinical team can customize the protocol for the individual patient. And then if patients are not experiencing any of those symptoms that might be indicative of an infection, then they're taken to their daily management plan, which is a video showing their airway clearance techniques and then kind of a checklist of things that they should be doing on a day-to-day basis. So the idea is not so much that patients would be in more contact with the team, it's that the system kind of preempts them with the knowledge that they need to kind of carry on their own if they can, and then if they really do need help, to know what to do.
And Caitlin, this is again fantastic work. I would encourage you that as this instrument matures, to be able to share that with perhaps maybe even at ERS in another presentation. Once you have you say product to and some maybe experience to share with the community at large, we'd all be, I think, very interested in this. And I also might just encourage you to and maybe have information about those domains of this program that are really consistent and not variable in a way, and those other ones that really highlight that individualized medicine part that you spoke of. Where are the touch points, if you will, that we need to really individualize for patient to patient, that we have to pay attention to, and that vary between the patients we see?
Absolutely. I think as we start to put this online, we're going to get a lot of good information about kind of what's universal and what is individual, and be able to target more. It's my hope that we'll be able to start being able to target things more individually.
And a shameless plug, James, do you have a date for the ERS deadline for abstracts?
We do, so it's in early February, so there's nothing shameless about that. We love the ERS, and
absolutely
get your abstracts in for early February. Yeah, there's something wrong with you if the idea of Barcelona next September doesn't fill you with joy.
Hopefully face to face. Amen, brother.
Yeah. Thank you very much for that presentation. I'm conscious of time, so we're going to move on to the next presentation. And as if by magic, Arietta has appeared. I couldn't see you 2 minutes. I couldn't see you 2 minutes ago on my.
Yeah, I was following the session through another computer, so I hope everything seems fine now with the technology.
Everything's perfect. It's like getting that real conference feeling when you see the speaker walk in 2 minutes before the presentation and everything's fine.
I was here before as well.
I know. No, brilliant to see you. And you're going to tell us about the use of nebulized medication in people with bronchiectasis, a questionnaire survey. Fantastic.
Yes, thank you. So can you see my slides? Is everything all right?
Not yet.
Okay. So I'm going to talk about the questionnaire we administered to the respiratory specialists.
I'm sorry to interrupt, Arietta. You may need to share your screen.
Okay, sorry. Is there a message you send me for that, or do I?
There may be a.
Just a minute, please. Yes, okay. Okay, sorry for that. Can you see my screen now?
Perfecto.
Yes. So I'm going to talk about a questionnaire we administered to specialists in respiratory care, and it was about the use of nebulized medications in people with bronchiectasis. So we know that We prescribe medications by inhalation to people with bronchiectasis. However, we don't have strict recommendation regarding the optimal inhalation device. In 2001, we have the ERS guidelines about the use of nebulized medications, and there is a list of some criteria for choosing nebulizers, but we don't know how the prescribers choose to administer inhaled medications, and this was a questionnaire that we used to learn more about how they do their decision making and what they also prescribe more often and how. So it was about the method of the administration of inhaled medications in people with bronchiectasis. We wanted to know more about that. This was a questionnaire that was sent through an email in 2019, a year ago, and the participants were respiratory professionals from the EMBARC registry. And the survey consisted of 11 items, mainly with multiple choice responses where they had to choose between different options. We had 130 participants who completed the survey, and they were from 27 countries, mainly from Western Europe and United Kingdom, some from Eastern Europe and some non-European countries as well. Most of the participants were physicians, and we had a few participants who were nurses, physiotherapists, and others, like pharmacists and so on. Our results showed that people prescribed inhalers, mainly when it's about long-acting bronchodilators, and they use nebulizers for administering antibiotics. They use inhalers for administering corticosteroids, and they mainly do not prescribe mannitol as we would expect, and they prescribe saline, isotonic saline, but mainly hypertonic saline. And you can see in these tables the percentages of the replies about how they nebulize the medications they prescribe. When it comes to the preferred delivery of the nebulized medications in people with bronchiectasis, we saw that the responders mainly preferred jet nebulizers or anything that is commercially available. And this is true for the bronchodilators, the corticosteroids and long-acting bronchodilators, isotonic saline and hypertonic saline. And when it comes to the antibiotics, they also choose vibrating mesh. So in conclusion, we saw that specialists prescribe bronchodilators, corticosteroids, and antibiotics and saline, but they don't prescribe mannitol. They use jet and mesh nebulizers as preferred choice for inhaled antibiotics, or otherwise they use anything that is commercially available. Thank you.
Good, thank you very much for that presentation. I'm a co-author on this poster, so again, I'm not going to give you too many difficult questions, I think.
All right, so let me then start out, and again, we'll open to the group for just a couple of moments. Can you share a little perspective on, you presented data about the preference of the respiratory physicians. Do you have any idea how that overlies with the preference and adherence from a patient perspective? That is, are we in alignment? And one of the tensions, if you will, that most of us that take care of patients clinically is, does my perception of what the patient wants and needs and will do match up and is in alignment with what the patient's perspective is? Do you have any idea or thoughts in that way?
Yeah, we didn't look at the patient's perspective in this study, so we didn't ask about how they decide in terms of the preference of the patient. There is a questionnaire that we are conducting at the moment where we ask patients to talk about their experiences in bronchiectasis, and it includes some questions about the nebulizations they use or other inhaled medications they get. So this might give us some insight about that. But what we see is that specific for antibiotics, there's clear trends for what people prefer to use. So this helps us understand maybe also the perspective of the patient, because probably if people don't use that, then the clinician might avoid prescribing it to other patients. What we know from others, from research and from studies, is sometimes that even with nebulization, what we prescribe is not always what the patient uses, when we have ways to track the specific and actual use of the patient, it's not always what we have expected. So I don't know if we are very clear about what's happening in real life with the patients. But yes, I don't. This wasn't a question we would be able to answer with this study.
Excellent. And
but
again,
it's very important though, because that's the actual real life.
Right. So again, I encourage you to pursue this and again, share and perhaps maybe develop this for another abstract at ERS, but very nicely done. And with that, I think in the interest of time, we'll move on. And James, do you want to introduce our next colleague?
Absolutely. So again, congratulations, Arietta, for that work. And we're going to move to a different aspect of bronchiectasis investigation now, which is looking at screening for non-tuberculous mycobacterial infection. So very pleased to welcome Anna Torrenti. Anna, are you able to share your slides?
Okay. The aim of this study was to determine the prevalence of MTM isolation in a cohort of bronchiectasis where MTM were routinely screening over 20 years period. Okay, since 1998, a mycobacterial culture has been ordered for all the patients with sputum production at the initial visit, annually, during hospitalization, in event of poor clinical control, and before initiating long-term use macrolides. In the last year, there was a change in the decontamination step and the addition of a culture-known liquid media. The identification and antibiotic-sensitive testing were performed at Vall d'Hebron Hospital in Barcelona. 290 out of 358 patients in clinic were included, 16% women, mean age at the last control 66 years, mean follow-up at 6 years, and mean of 1.2 culture per 4 patient year. In 5% of the patients, MTM were isolated. The most common MTM isolation were Mycobacterium avium complex and Mycobacterium abscissus. Two patients met the diagnosis criteria for MTM pulmonary disease by Mycobacterium avium complex. Two patients were persistently isolated Mycobacterium abscissus. 3 patients were intermittent isolated Mycobacterium avium complex, and 8 patients with transient isolated. Mycobacterium tuberculosis were incidentally isolated in 3 patients at the beginning of control. The 2 patients with MTM pulmonary disease received treatment, one with eradication and the other one with persistent MTM isolation despite several treatments. The 2 patients with persistent isolated of Mycobacterium abscissus with severe bronchiectasis after more than 10 years of follow-up with progression on function tests without changing on CT, and were treated, one with eradication and lung transplant and the other died for respiratory failure. We conclude that MTM isolation are low in our area, as well as revealing the 2 prevalence in each area. Routine screening for MTM bronchiectasis permits early detection and treatment. Thank you for your attention.
Thank you for your excellent presentation. It's a large cohort of patients with bronchiectasis, extensive testing for NTM, and a low prevalence, as you said, compared to some of the series that we've seen. I've heard some of my other colleagues who work in Spain also say that they think Spain has quite a low prevalence of NTM. So my first question is, do you think this is unique to your center, or do you think it reflects a low prevalence of NTM in bronchiectasis in Spain?
I think that it must be because in Spain the prevalence of tuberculosis is high, and the climate here is dry, and could be is the reason that it's low in our country.
Fascinating. And so what do you do in routine clinical practice in terms of identifying NTM patients and screening for NTM patients? What's your protocol for how often you test?
Our protocol and the first visit, we ordered this type of culture, and then we ordered annually, okay, and when the patient need to go to come to the hospital, and when the patient have a exacerbation of the bronchiectasis, and before use the macrolides, we order this culture and we recollect it and see if it's grown or not.
And can I ask, do you use a lot of macrolide in the practice in Spain for bronchiectasis?
Not at all. We use it when we have a severe bronchiectasis and we want to control the severe infections, but normally we don't use it.
Very good.
Depends on the patient.
Opening it up, of course, to questions from any of our other colleagues on the line. Any questions or comments? So you had a few cases there of Mycobacterium abscessus in non-CF patients. I see that, but I see that very uncommonly. I'm wondering, would you do any specific investigations when you identify a non-CF patient with Mycobacterium abscessus, and particularly do you screen those patients for CF?
Normally, we do it more visits and to have more control to know if it improves the clinical with the treatment or not. It needs some more medication or something like that, and this is what we do it.
I think you need more fomites coming from the UK to Spain.
I mean, Tim, do you want to make any comments about this with the sort of the data? The United States functions as a kind of interesting climatology prevalence of NTM experiment, because you have the same country but with very different climates and therefore very different NTM rates, and that might have some insights for what we're seeing here for Spain.
Yeah, so it's a great question. I think the jury's still out as far as what the exact meaning of all the data is. And there clearly are more environmental mycobacteria in the US, depending on the location geographically. And certainly in the southeast, and the hotspot in the US, of course, is Hawaii, thinking temperature and humidity. But having said that there are other pockets. So around the Great Lakes, for example, in my neck of the woods in the upper Midwest, around the Great Lakes, there are some pockets of MAC and other NTM that show up. And so there probably are a number of factors that are involved, but the environment does have some impact on exposure. And then presumably coupled to that, this multigenetic model that Ken Olivier talks about then superimposes why we see then the phenotypic development of mycobacterial pulmonary disease in this way. I don't know that there are distinguishing characteristics necessarily for abscessus over MAC, but that's an area under active investigation. It was interesting that with the initial some environmental sampling, shower heads, biofilms, slime assessments, that in some instances, some of the NTM that are prevalent in the clinical cohorts don't show up in the plumbing. Again, I think the jury's still out, but it is a complicated, I think, set of relationships between the environmental exposure, which clearly has some impact, and then the host susceptibility in a presumably multigenetic fashion.
A fantastic discussion. Thank you very much for sharing that data, and particularly with all the challenges at the beginning to get connected. So excellent.
Well
talk,
done.
and thanks for answering the questions.
Thank you. Yeah. Thank you.
There we go. So we have one presenter to go, because I don't see the penultimate presenter in the room. So Dr. Constantin, I don't see. So I think we can move to Dr. Maselli, if you're happy with that, Tim.
I am. Diego from San Antonio. It's great to have you with us and to be able to share what looks like absolutely fantastic work and starting to bridge this chiasm, if you will, between COPD and NTM bronchiectasis patients. So this is absolutely fantastic, and be interested to hear your perspectives.
Thank you.
Dr. Maselli.
Can you hear me well?
Yes.
Great. Thank you so much for the opportunity to present. Thank you so much. Fantastic Congress. So the title of my presentation is Small Airway Disease and Emphysema that are associated with future exacerbations in smokers with radiographic bronchiectasis and COPD. So really our group working a lot with Harvard Medical School, we're trying to understand a little bit better what is the impact of finding bronchiectasis on CAT scans. So what we have done is we've tried to use data from the COPD gene cohort and try to understand a little bit better what does it mean when you find bronchiectasis in some of these patients. The COPD gene study included around 10,000 patients. So I'm gonna skip here a little bit. So included like 10,000 patients. These are patients that all get a CAT scan. They have an exclusion criteria of bronchiectasis. So automatically patients that had the clinical diagnosis of bronchiectasis were excluded. And everyone gets a scan. But it's interesting that as you look at some of these scans, you do find bronchiectasis. Most of the time they're milder forms. Occasionally there's more severe ones. And what we did is we took, we reevaluated the CAT scans, specifically looking for bronchiectasis, around 1,000 of those. And we were able to find 387 patients that had bronchiectasis, again, on the milder side when it comes to the severity. And what we were trying to do is we were using this relatively new technique, which is parametric response mapping, to try to objectively assess small airway disease and emphysema. And this is like a voxel-based methodology where the image is analyzed by a computer, and it can determine objectively the degree of small airway disease. So what we found was, again, these patients were prospectively, what we found in this case is with out of all these participants, we had bronchiectasis evidence on CAT scan. Some of them had some exacerbations, not a lot, 0.3 exacerbations per year, but they did have a 9-year follow-up. So we had a lot of information about that. And when we looked at small airway disease specifically using this parametric response mapping technique and emphysema, when you have that, you actually can predict future exacerbations in this cohort, both emphysema and small airway disease, again quantified objectively by this parametric response mapping. So sorry, I'm jumping a little bit back and forth in the slides, but just so, because this is the actual poster, as you can see, when you have both patients that have COPD and non-COPD together, it maps relatively well. But when you separate the patients actually using parametric criteria for COPD, you can actually see that there's some diversions there. So when you exclude the patients that have no COPD, that signal gets lost. So it's actually more specific towards those patients that have both COPD and bronchiectasis, where you can see that actually the small airway disease and the emphysema will be predictors, or at least can increase the risk of future exacerbations down the line. Again, this is a 9-year follow-up, and we're still trying to understand the implications of this. But what it appears to be is that even in even in patients that have not that severe bronchiectasis, these changes that might be subtle on CAT scan that cannot be picked fully by the eye, right? The radiologist cannot fully call these things, but when you do objective measurements, using these algorithms with a computer, that you actually start to detect some signals that might be predictors of some outcomes in patients with even mild bronchiectasis. So that's in a bit of a rush in a summary of what we did.
So this is extraordinary work, really, really fascinating. What do you think is the reason that you only see the exacerbation signal in the patients that have bronchiectasis? So why don't we see a signal in the COPD population, or an association with exacerbations, I should say?
So
you probably didn't have time to go into it. Is that because they have fewer exacerbations, and so you have less power, or what do you think that is?
I think that's the case. I think there's just a little bit less power. The number of exacerbations are low, relatively low. So that's I think part of the reason why that is. In what it appears is that you have to have both bronchiectasis and I mean not only bronchiectasis but also spirometric COPD to have the higher likelihood of having exacerbations. So it's likely driven by the COPD component of it. But in these cases, even the patients with bronchiectasis, I mean, can still have a little bit of a risk. So it's hard to be 100% sure. And you see the rate is relatively low, so maybe it's a power.
Yeah. Okay. So that's important. Do you think that this is causal in any way? So I can imagine how small airway damage and small airway inflammation could lead to exacerbations. Emphysema, I'm slightly woollier on how that would increase exacerbation frequency. What do you think's going on there?
Yes, that's a very good question. So I think with a small airway disease, you can assume that, as you said, with emphysema, I mean, we're not 100% sure. I mean, it might be just a progression of the disease. As you know, in COPD, there's some degree of some theories that there's some active, when there's emphysema, there's some active inflammation, although sometimes that's not always the case, depending on what biomarkers you use to assess that. So maybe emphysema is, to some extent, a secondary result from something that happened before to the patient, so, or perhaps the architectural changes of the lung or the airways may promote exacerbations. I mean, in patients that have low FEV1s and COPD, they're obviously a little bit of a higher risk, not all of them, to develop future exacerbations, but it's not fully clear.
And I guess I'm very impressed that the curves, or at least the curves, look almost superimposable, whether it's emphysema or small airway disease, over those two, suggesting that they're not discriminatory, whether you're using the PRM for small airway disease or for emphysema. And so it raises this possibility is, do they really have emphysema, or what is emphysema in your title? You had future exacerbations in smokers with bronchiectasis. And is that part of the issue here, or is it really COPD patients with bronchiectasis?
Yes.
And I guess it's a semantic term, but begins to scratch at what are we actually really talking about?
That's correct. And you're right. I mean, we don't know. You're right. I mean, these are patients that have COPD, some of them, but not all of them. And that is when you start to separate between those that have spirometric evidence of COPD, then that's when you see the signal disappear. But it's semantics. You're right. I mean, these are smokers that have bronchiectasis, and some of them don't meet criteria for COPD based on spirometry. So that's why, that's the title. That's the reason for the title.
I think it and I don't know, I guess defer to James on this one, but I mean, this does open up this whole can of worms of, about event rates and what are we actually looking at when we see our patients, and can CT scoring help further discriminate these groups? And I think there's a lot to be had here.
Yeah, I do as well. I think as a final question would be the practicality question, Diego. So in order to operationalize this, we'd have to be able to do it in a clinical trial or in clinical practice. I presume I can't do parametric response mapping in my hospital right now. So how would we use this information in practice or in studies?
Yeah, so that's a fantastic question. So the applications of these is how do we apply this in clinical practice? These techniques are under development, but it's interesting that the computers, the algorithms for evaluating CAT scans continue to improve and improve. And for example, now there's some emerging algorithms that can tell you percentage of emphysema, just like that, and it's very accurate, particularly for COPD, obviously, which is relatively easy. We still obviously not yet to put it in clinical practice, but it just increases the tools that we are coming in the future, where we're going to be using more the computers, more artificial intelligence sometimes to even assess the imaging. And it's very interesting, just as a side note, a computer can take to assess emphysema seconds sometimes, where radiologists going slide by slide by slide can take sometimes hours to go. So a computer can analyze 5,000 patients in relatively quick time, just to determine, for example, emphysema. And a radiologist may take a long time to do that. So for clinical trials and for things like this, it just enhances a little bit the tools that we have for the future. It's still obviously in diapers when it comes to how are we going to apply this to your hospital or my hospital. But it just gives you additional insights of what's in the future. I think in the future, we're going to have more information coming from radiology and from the computer and artificial intelligence even. So it's just some concepts in development.
Yeah, I completely agree. I think this is going to be the future, and in the very near future, I think we'll be getting artificial intelligence or automated CT as part of our our daily routine. Thank you so much, Diego. That's a fascinating talk and a great way to end this this poster session. I'd like to thank all of our speakers who've given a really exciting, interesting session. Lots of opportunities for interaction. And I'll leave the final word to Tim.
And again, a plug, continue the great work. I would encourage you to submit your abstracts for ERS. James, do you want to mention the bronchiectasis and NTM workshop just for the rest of the group?
Absolutely. So we will be doing this again next summer, and having had this experience, I'm sure we'll all be desperate to get back together. Let's hope it's face to face. But even if it's not, we've shown that we can have a really good academic discussion online today. So let's get together for ERS next year and for the workshop.
Right, and strong work to all the speakers. Fantastic.
Thank you so much.
Have a great rest of the meeting. Thanks, Diego.
Thank you.
Ciao.
Thank you.
Bye-bye.
Bye-bye.